Hello and welcome.
Hi, thank you.
Please give us your background and area of expertise.
Yeah, my name is Jamie Feusner, and I'm professor of psychiatry at UCLA. I'm the director of our adult OCD program and also director of our eating disorders and body dysmorphic disorder research program.
How are current treatments insufficient in addressing the needs of patients with obsessive-compulsive disorder?
So I think that the state of affairs right now with OCD treatment is that there are three major areas that are problematic. So one of the areas that I think is problematic is simply the access to care. We have some treatments that are effective for the majority of patients, such as cognitive behavioral therapy, a special type called exposure and response prevention therapy, and also medications. And with the exposure and response prevention treatment, which can be effective treatment and may have some long-lasting effects, unfortunately there aren't enough well-trained therapists to deliver this. This is particularly a problem in areas that are not in major metropolitan areas or rural areas where there are even fewer therapists in general. But it's even a problem in metropolitan areas because some of the therapists that are well trained, unfortunately, may not take insurance, or it may be very expensive for people. The other major problem, I think, is that we still don't know enough about the brain in people with OCD to effectively develop treatments that are rationally designed to help either improve symptoms or to overcome symptoms in different ways. And the third major problem that I think is that we still do treatment in a pretty much a kind of trial and error format. So we know that these treatments work on average for people. That's the studies are done, and they demonstrate on average that these treatments work, and so we apply them. But then what happens is that it may not work for every individual person, and then we have to go and try the next one. So it's kind of a one-size-fits-all approach and a trial and error approach. But in OCD, this is really a particular problem because some of these treatments, for example, medications, sometimes they can take upwards of 3 or 4 weeks to start working. So it could take 6 or 12 months even to find the first treatment that can work for them.
What is resting state brain connectivity, and why is it important?
So first of all, starting with brain connectivity. Brain connectivity is referring to how brain regions are activating in synchrony with each other. So this is simply a correlation of activity levels in different regions of the brain. We say they're connected as measured by functional neuroimaging, for example, if they are correlated in their activities. And it's important because this likely is indicating that these regions are communicating with each other. And so brain communication is very important. Our brain is a very highly dense interconnected network, and we use almost all of our brain to do almost everything that we do. So for example, a simple visual task, we use the majority of our brain just to do that. So we understand that many of these psychiatric disorders, like OCD, really involve multiple systems in the brain that communicate with each other. And to understand the pathology and understand better treatments, we need to understand how these brain systems are communicating with each other. The resting state part of it just means that their person is not doing a task when we measure this. So for an example, in the fMRI scanner, we have people just lying there with their eyes open or eyes closed. It's a very easy way to be able to get information and to repeat the experiments in different places. So for example, we were able to use resting state brain connectivity in our recent study to be able to predict outcomes. And that kind of addresses one of the issue of can we efficiently figure out who might respond better to a certain type of treatment, in this case, exposure and response prevention. We also used resting state connectivity to figure out what parts of the brain change with treatment from exposure and response prevention. We found that there are very important changes that happen, very high magnitude changes in connectivity from the cerebellum to the striatum and the prefrontal cortex that seem to be associated with symptom improvement.
Thank you.
You're welcome.